Hello and welcome to the EKG competency training video, the 3Ps, patient prep and positioning, which is compiled by the Southwestern Illinois EMS Chest Pain Subcommittee. Following this tutorial, there will be a short quiz required. So let's get started. So what is the value of a quality EKG? Obviously, quality EKGs are very important in preventing misinterpretations, and they're crucial to our patients' outcomes, especially when dealing with the ACS patient. Obtaining quality EKGs eliminate the need for retesting due to certain things like signal interference or noises and other reasons why we get poor quality EKGs. Here are some causes listed. Research shows that the vast majority of these EKGs are due to improper skin prep, which I know for a fact in the field is one of the biggest things that contribute to poor acquisition. Other common causes are obviously electrode misplacements, lead reversals, or poor techniques. I'd like to add also that sometimes the use of pre-opened electrode packs where the conductivity gel has dried out is a culprit in this as well. Here are some non-cardiac causes. You have muscular activity, tremors, clenching, patient movement and shivering, anxiety, hyperventilation, and even some significant electrolyte imbalances. There's some external causes, some of that artifact. EMI, or electromagnetic interference, which can be caused by cell phones when dealing with medical equipment. Not only cell phones, but other devices in the room may cause that as well. Sometimes we'll see some tall, spiky waves or some fuzzy bass lines, or even they may even also mimic some real or even hide some real EKG changes, specifically mimicking STEMIs. And at the bottom here, it just says basically we need to ensure that the cell phones are at least 3 feet away from the areas when acquiring these EKGs. So the first P is the patient. Things to consider when dealing with a patient receiving an EKG. Make sure they're not cold. Shivering produces artifact. Patients need to lie flat or even in a semi-recumbent position when acquiring these EKGs. And we understand that sometimes they're dealing with these patients. They're also short of breath, and we may need to explain to them or coach the patient at least when acquiring these, basically conveying the importance of getting a quality EKG in the short period of time. That way we don't have to retake one. Second P, as I said, was skin prep, or poor skin prep is probably the most, like I said, the overlooked step in acquiring EKGs in EMS. Top 2 layers of the skin are dead, and we need to clean these areas or wipe these areas down. Like I said, our goal is to increase the conductivity and reduce resistance. Also on skin prep, sometimes even abrading these areas are necessary. This can be done with the included emery paper on the back of some electrode packs. I know they have some emery board paper that come with certain brands of electrodes. It's also found that even the rough texture of a 4x4 or even a simple pillowcase could help accomplish this. Here's a simple acronym to remember when performing skin prep: clean, clean hair away, leave no lotions, powders, effectively dry the skin, abrade the skin to remove dead skin cells, and never forget to perform skin prep. Like I said before, utilizing a 4x4 linens will help to ensure proper lead adhesion. And here are some bullet points on skin prep. Just taking the time to do this is probably the most important thing. If we take the time to do this, we will be successful, or at least increase our succession in getting our successful rate in getting quality EKGs. And the third P is position. Obviously, this is very important in where we even place the limb and V leads in acquiring quality EKGs. Remembering that your order, limb leads first, chest last. This is a demonstration of how to properly acquire 12 lead EKG and proper pad placement. For demonstration purposes only, we'll assume the patient is in a semi-recumbent position, as well as the skin has been prepped prior, wiping away any dead cells and body lotions before applying the electrodes. The limb electrodes, notice the placement of those in the outermost portions of the limbs. We now stair step down, identifying V1 in the fourth intercostal space on the patient's right, and apply that there. The paramedic will then also transfer over to the patient's left side, identifying fourth intercostal space directly on the opposite side of the sternum for V2. Medic now then stair steps down in to identify the fifth intercostal space, mid-clavicular, and applies V4. Now we go back in between V lead and V2 and V4 and apply V3. Along that same line, the medic will then transfer to V6, going mid-axillary. And then, of course, finally, we'll do V5. We'll fall between V4 and V6. Position the electrodes is very important. Make sure they're on flat, fleshy, non-muscular parts of the arms and legs, obviously. When placing the arm lid leads, make sure they're on the inside of the arms between the wrists and shoulders, closest to the wrists. Also, in dealing with the legs, calves between the ankles and knees, closest to the ankle. Sometimes in males, we'll have to get rid of a little bit of hair as well to make that adhesion possible. Here is a positioning effect, an adverse effect, when we look at what can happen when we simply reverse the right arm and left leg electrodes. This can actually mimic an inferior infarct. Just think about that for a second. This can have significant effects on our treatment and overall impression of this patient. So keep that in mind and ensure that we're putting those limb leads in the proper locations. To test for to make sure that you got a good firm electrode contact, they ask to slightly tug on the electrode. Don't pull on the lead itself because that could cause some damage, but just to make sure that the electrode is nicely stuck on the patient. And also, like I said before, that the using new electrodes and unopened packs is indicated for these, so we don't have that conductivity gel drying out. They say the number one cited factor in inaccuracies in the precardial lead misplacement is the V leads, V1 and 2 being too high and 4 through 6 being too low. It's important to identify the intercostal spaces when placing these leads. Guessing where the V leads go is just unacceptable. And eyeballing. We should be putting our hands on the patient, stair stepping down, and counting those intercostal spaces to ensure that we are getting these V leads in the appropriate places. Here are the anatomical locations and where you do place those. Obviously, you'll stair step down into the fourth intercostal space for 1 on the patient's right side, quickly followed by 2 on the other side of the sternum. Next, we place 4, which is mid-clavicular in the 5th intercostal space. Next, we place the 6th along the same line, but we go mid-axillary for that. And then 3 obviously goes in between 2 and 4, and then 5 between 4 and 6. Here are some steps to obtain printout and transmission. This is probably the utmost importance transmissions of our 12 leads. Paying particular close attention to transmitting a 12-lead EKG to your receiving hospital as soon as possible. I don't know how much I can emphasize on as soon as possible, but this allows for early activation of that cath lab and gets those things in motion to receive this patient and to make the process as streamlined as possible. Now, we understand that there are moments when acquiring 12 leads inside a residence where we may lose connection with the ambulance's router. So pay close attention to ensure that the transmission goes through. Most all cardiac monitors will give us a confirmation if our transmission was successful. If your transmission fails and you have identified a STEMI, call the hospital and transmit as soon as your monitor has reestablished connection with your unit's router. So that once we get out of the house and we reestablish that connection, we should be able to send that EKG that we just obtained to the hospital. Notification, obviously another very important step when dealing with STEMIs. Early identification and notification is the utmost importance. But one of the things we definitely as a group have identified is the use of common terminology or verbiage. When dealing with a STEMI and calling a STEMI, always use the exact term code STEMI. This helps to eliminate some misconceptions and some confusion between us in the field and the receiving hospital. Don't hesitate either. Just call it, activate it, and use the words code STEMI. The hospitals in the regions want us to know that you should never be faulted, or we as EMS should never be faulted for false activations. Data has in fact showed that we in EMS, for the most part, are we have relatively low false activation numbers. So they want you to know that to have that fear, we should be calling these regardless of our fear. If we believe this is a STEMI, you should be calling it a STEMI and using those exact words, code STEMI. We as healthcare providers should never fear false activations and should never be chastised or belittled for our efforts. If you ever are, the hospitals want you to know that you should report this to your supervisor, because all hospitals and even the region has ensured that this should not be tolerated. We're all here for the better of the patient, and if you believe this is a STEMI, that's in fact what you're calling it, then and if you have done all the proper steps, then you should not be faulted for that. Next, we have some right-sided EKGs, or when you'll need to do those. Dextrocardia obviously is your anatomical thing that may be happening with your patient. Hopefully, they'll be able to tell you that they have dextrocardia and will need to reverse and do a right-sided EKG. Obviously, you need to remember also that those limb leads will need to be reversed as well. So in summary, now that we understand that quality EKGs are very crucial and can affect several facets of the overall care of our ACS patients, we have a better understanding now of the process. And this will get our patients the fastest, most appropriate care that they so deserve. Special thanks to all of the following agencies for their dedication to this project: Memorial Hospital, St. Elizabeth's Hospital, Abbott, MedStar, and O'Fallon Ambulance. We will now be required to complete a short quiz on what we've learned here today. Thank you very much.